Hi, I'm Jose Joglar from the University of Texas Southwestern Medical Center. This is the AHA Science News. We are honored to have Dr. David Conen, the principal investigator of the COP-AF trial. I know colchicine is a very old drug, but it has is being seen a revival recently. There's been a lot of studies looking at new indications for this drug. So perhaps Dr. Conen can tell us a little bit about the COP-AF trial. Welcome, Dr. Conen.
It's a pleasure to be here. So we planned COP-AF based on previous studies showing that colchicine can reduce perioperative atrial fibrillation in cardiac surgery and ischemic events among patients with coronary disease. We looked at patients undergoing non-cardiac thoracic surgery, and we tried to prevent perioperative atrial fibrillation and myocardial injury after non-cardiac surgery, which are ischemic-related troponin elevations after surgery. We enrolled 3,209 patients across 11 countries. We followed them for 2 weeks. The primary endpoints I already mentioned. We found a strong signal for both primary endpoints, but none of them were significant. So there was a 15% non-significant relative risk reduction for perioperative atrial fibrillation, and there was an 11% non-significant relative risk reduction for myocardial injury.
So the trial, you found a signal, but it was not statistically significant.
Correct,
and
right.
I know there have been a lot of debate about the use of this drug to prevent atrial fibrillation after cardiac surgery. I assume that's the rationale behind, the impetus behind this COP-AF trial. There have been recent trials, as you know, for preventing AF after ablation. And there's a lot of debate about what is the right dose. One of the issues, side effects from this drug. I know you guys use 0.5 milligrams twice a day on your patients. What are your thoughts? What is the right dose? What are your thoughts about this?
So we used 0.5 milligram twice daily for 10 days. The long-term prevention studies in coronary artery disease patients use mostly 0.5 milligram once daily, because it is true that there's a dose-dependent increase in diarrhea risk. In our study, there was a 6% absolute increase in diarrhea in patients taking colchicine twice daily. These episodes were benign, but nevertheless present. So I think the right dose is still up in the air. I am not sure we can go much higher than 0.5 milligram twice daily because of this diarrhea side effects. And if you go much higher, you will also find other side effects known related to be related to colchicine. So I think for the surgical field, given that there's such a strong inflammatory rise after surgery, at least a few days of twice daily are probably reasonable, but the longer you start treating patients, the more you will go back to 0.5 milligram once daily to try to prevent these diarrhea episodes.
Any data on inflammatory markers? Did you guys collect that to see if there was a difference between patients who have higher markers for inflammation or?
So we did not collect any biomarkers for inflammation or any blood samples in our study, because this was a large pragmatic international trial. It would have been too expensive to collect this information. However, I think in the post-operative world, there's a slight difference compared to the stable coronary patients, because there is no doubt that there is an increased inflammatory response after surgery, and everybody will have that who has a reasonably sized surgery. So I think trying to prevent that post-operative inflammatory peak is valuable, independent of the CRP or whatever inflammatory marker before the surgery.
So what are the next steps? The study, like you said, there was a little bit of a decrease on atrial fibrillation, not sure that led to hard outcomes like preventing hospitalizations, et cetera. So what happens next? We don't have any other studies in your mind, or we just don't think this is a good option for preventing AF after non-cardiac surgery?
I don't think we are discouraged by the results. There is a strong, consistent trend, especially for the ischemic events. I haven't talked yet about the secondary outcomes. They were all not significant, but there was always a 10 to 20% relative risk reduction for various composites of stroke, MINS, myocardial infarction. And there were two post-hoc composites of the co-primary outcomes and another one that were statistically significantly reduced with colchicine. So I do think there is a signal. We need to dig deeper into data, and then we will need another trial that looks, I think, in higher risk patients from a vascular perspective, because in our trial, only 9%, for example, had coronary artery disease. And so in a higher risk population, trying to prevent cardiovascular outcomes and also maybe AFib, I think is still a very reasonable option. These are important complications after surgery that are common. So trying to prevent them is still a reasonable option. But our trial was unfortunately in part not powered enough, and maybe we need to tweak a little bit the design, and then we hopefully will come up with a more definite answer in the future.
So maybe in the higher risk population for AFib, I know there have been some score system utilized by the cardiac surgeons, and they have been proposed as a possibility, right?
Yeah.
Well, thank you so much, Dr. Conen. It's been a pleasure having you here, and I wish you great luck, and thank you, and be well. Take care.
Thank you so much.